Okay, are you guys looking at slides? Yes. So now I'm looking straight at you guys and my slides. It's brilliant. Okay. All right. What am I shooting for 15 minutes? Is that right? I'm going to say 15. Okay.
Yes, 15 minutes. You got it.
Thank you. So yes, I have launched these sessions. I think this is now my third or fourth time or time around here, and we felt like that harm reduction is a great topic to start this off because it's pretty broad, and I think it carries with it a general philosophy and attitude that is pretty necessary for effective interaction and support of folks who are either at risk for addiction or already actively addicted. So let's see. Okay. All right. I have no financial conflicts of interest to disclose. All right. So real quick, we're going to go through real briefly trends in opioid overdose. I mentioned earlier a report that just came out from some national EMS data that suggested a spike in overdoses in 2020. I don't currently have any supportive data on that to understand what that trend is about, but I think maybe we could, if we had time to discuss it, we would come up with some ideas given all of the stressors of 2020. Risk factors for misuse, abuse, and overdose. What is harm reduction and how it can be used to prevent overdose, and then incorporating harm reduction into primary care or addiction medicine practice. So Dean Wyckoff told me once, never underestimate the value of telling people what they already know. And if you sit with that for a minute, it's pretty profound. So I'm going to do that right now. A lot of us are pretty aware of what the world has been experiencing with regard to what I refer to now as the addiction crisis. It has been called the overdose crisis or the opioid crisis, but starting really beyond where these figures go in the 90s, we started to see a spike in opioid overdoses and deaths, but we started to see that kind of flatten off in the last 5 to 7 years as we've gotten a handle on the just volume of prescription medications in the wild. And unfortunately, folks had already found themselves dependent, had to move to street drugs such as heroin, and we've seen dramatic spikes in overdoses from that drug itself. And then in a third wave, we saw fentanyl, which is a synthetic opioid, 50 to 100 times stronger than morphine, being the causative agent behind a huge spike in overdoses, predominantly because of accidental exposure as people do their drug of choice, whether it be powdered heroin, methamphetamine, cocaine, basically anything that resembles sort of a white powder. Fentanyl can mimic it, and folks are accidentally exposed and overdosing. So, and obviously, I'm going to keep saying obviously because I know that I'm speaking to the choir a little bit here, but where you live matters. We talk about this a lot in public health, sort of the whole milieu of where you live and all the factors that go into where you live definitely are predictive of sort of population rates for overdose. And you can see Appalachia has really from the beginning of the crisis starting in the 90s has borne a huge burden of the overdoses in the country. So if we talk about, it's a step all the way back to misuse into use disorder as we, move backwards from overdose, what are the risk factors associated with that? And there's probably as many risk factors for misuse as there are people in the world. But just to name a few, so we know that poor mental health and physical health play a role. Sort of what we experience as children certainly has an impact on our behavior as adults. If we are experiencing poor social support, we have a family history. There are certainly some hereditary drivers for addiction. Access was something that played a huge role with the prescription opioid crisis, given the just overwhelming distribution of those substances, especially in rural areas. Lower perceived risk, again, playing a role with the prescription opioid crisis. You know, if doctors say it's safe, then, you know, that definitely breaks down some walls in a person's willingness to approach a drug. And then, you know, sort of beyond that, so that's, you know, we've experimented, perhaps, you know, triggered something in our brains that responds really positively to the substance, and so we've moved into substance use disorder, and then we're at great risk for overdose. So frequent use and high dosing is something that definitely contributes reduced tolerance. So folks who recently get out of you know, being incarcerated, you know, they've gone in a lot of times. You know, a lot of incarceration is drug involved, and so you know, getting out after sort of detoxing and going back to your original dose can be fatal. Same is true for treatment. Having a previous non-fatal overdose. So generally just sort of being a part of that population that has some behaviors that have contributed to your original overdose, using alone, mixing, age and physical health. So sort of, you know, how your body, you know, is capable of responding to the level of substances being, you know, introduced. And then the drug quality. So I've already mentioned fentanyl. You know, it having sort of that accidental exposure can be devastating, but also, you know, just sort of the variability of drug quality in the illicit drug market contributes to overdose, just as people try to manage what they think, you know, the potency of their substance of choice will be. But also folks who have legitimate prescriptions, you know, risk factors include having multiple prescriptions, stockpiling those, mixing them, you know, and sort of on our end of things, you know, thinking in terms of solutions rather than problems, you know, sort of patient-doctor relations, so increasing communication to help folks with their prescriptions and manage those to make sure nothing gets crossed or you know, overdosing. And then, you know, again, focused on pharmaceutical pain management as part of that communication. All right. So what is harm reduction? You know, formally, it's defined as policies, programs, and practice aimed at reducing negative consequences associated with drug use or other risky behavior. I take a broader perspective on that. I've already suggested that my Bahama t-shirt or shirt is somehow harm reduction, which is of course absurd, but I think too that, you know, we can think in terms of, you know, distributing condoms to teenagers as potentially harm reduction for unplanned pregnancies and incidents of sexually transmitted diseases. So some of the strategies that we do employ formally in with regard to opioid use disorder. So first and foremost, we want to reduce stigma in ourselves and in others. So we try to remove any moral or ethical judgment around substance use. Substance use as a term is part of that. So rather than saying substance abuse, we've moved to substance use to sort of reduce that potential stigma from the language. Increasing access to evidence-based treatment, which often can include medically assisted treatment, which is a harm reduction strategy. Increasing access to naloxone. So this, you know, has been less of a leap for folks in recent years, but it used to be pretty controversial that we may just be encouraging folks to take as much drugs as they want, and they can overdose and we'll bring them back. But that perspective doesn't enter into a harm reduction strategy. So teaching safer injection practices and safer use, providing access to needle and syringe exchange, and considering the implementation of safer injection sites. So looking at harm reduction across the spectrum here from you know, an individual not using to an individual dying from an overdose, you know, we start in primary prevention, which is about preventing misuse. So we're working to prevent experimentation with substances, and this often takes place in a adolescent population, which is high risk for any sort of accidental morbidity and mortality. then into secondary prevention, where we're screening and we're educating folks who may be misusing substances and putting themselves at risk for a use disorder. And then into this far right side here, where we're working with folks who are dealing with an active addiction and ways that we can reduce the harm associated with that use. So medically assisted treatment is a great example of that. You know, providing the physiological needs for that individual, so that we can remove the social and perhaps criminal outcomes of, you know, relying on an illicit drug market to meet your physical needs. And then naloxone on the far side here, where we are basically, you know, we can't prevent someone from overdosing, but we can potentially prevent them from dying from that overdose. And so incorporating this stuff into clinical practice can be pretty straightforward or very complex. You know, we can screen folks as they come into primary care settings, just talking to people, you know, being willing to talk about these topics around addiction, perhaps providing some counseling service, and then prescribing buprenorphine. So being a provider, getting a waiver, so that you're able to treat that population that's at risk for overdose. Of course, if you're prescribing an opioid, to be able to also co-prescribe naloxone. So medically assisted treatment, that's methadone, buprenorphine, naltrexone, is highly supported by the evidence and is endorsed by you know, all the federal agencies that deal with mental health and substance use. So if, you know, folks are opposed to this, you know, it's not, that opposition is not typically based on the evidence, because you know, the numbers are in on medically assisted treatment. Naloxone, also very effective in reducing overdose mortality. It's very widely used at this point, but still has a long way to go. There are striking, you know, reports to look at that show the impact of distributing naloxone in communities that are dealing with a lot of overdoses. Syringe service programs are my favorite harm reduction program. They were conceived in order to reduce the spread of HIV in San Francisco back in the 70s and 80s, and you know, have really shown to be capable of providing a whole sort of host of services around them. It's essentially a service that's necessary for this population. So if you build it and it is appropriate and acceptable, they will come, and in doing so, you can interact with them and provide a lot of other services around that. So some of the key tenets of harm reduction, basically we want to minimize harm versus ignoring or condemning the behavior. We're focused on functioning and well-being rather than cessation, acknowledging that there's a continuum of behavior. So, you know, there is a continuum of risk associated with substance use. It's not, you know, if you use substances, this is your risk, but there are things you can do within that behavior that can reduce your risk of overdose. So acknowledging that, recognizing the cumulative effect of social determinants. So back to our map earlier, where you live matters. Remains neutral on legalization and decriminalization, though I can tell you there are certainly some poorly conceived legal policies that contribute or can contribute to overdose. And it maximizes intervention options. And this is, you know, my favorite piece here, thinking in terms of the stages of change. I think our clinicians, our primary care docs think about this a lot, and we think about it a lot in public health and psychology, and just sort of the cycle that we go through as people. When we're providing harm reduction services like syringe programs, we're able to interact with folks at a pre-contemplation. If we're thinking in terms of treatment, you know, before anyone is seeking treatment, we're able to interact with them and provide support services and hopefully reduce morbidity and mortality around their substance use. So harm reduction in the clinical setting starts with responsible opioid prescribing principles when we're talking about opioids. using non-opioid therapy, starting low and going slow, and doing close follow-up. I know, again, preaching to the choir with this stuff here. SAMHSA has an overdose prevention toolkit that has a series of strategies involved. So making sure everybody knows how to identify and manage an opioid overdose, ensuring access to treatment, ensuring access to naloxone, encouraging folks to call 911. This is a big one. Even folks who have been using for years and years aren't aware of Good Samaritan laws that allow them to call 911 and not fear prosecution for having drugs on them, I think, to a certain amount, or potentially contributing to the overdose, though those laws are changing as well. And then encouraging prescribers to use the prescription drug monitoring programs, which I think we're all aware of those. So ensuring access to treatment, this is kind of a focus of this group, maybe perhaps in our previous ECHO, but also in this one as well. So encouraging, we feel that, and the evidence suggests that, low threshold or increased access to buprenorphine treatment for folks can prevent overdoses. And so, advocating for that. So, effective treatment obviously can reduce overdoses, either providing or knowing how to refer for treatment for opioid use disorders or substance use disorders. So knowing your treatment environment around you, and perhaps working with some of those folks to create ease of referrals. And you can find information about this stuff on the state health department websites, as well as SAMHSA. So what you can do in the office setting, again, patient-centered care is what we always promote. Integrating primary and behavioral health care can be difficult, but it can be very effective in treating the whole person. Considering, obviously, offering treatment, providing counseling, and maintaining flexible treatment goals is important. So, working to not fire patients, but recognizing sort of the cycle of relapse in this population. Establishing, as I mentioned, collaborative relationships with the treatment providers in your area, and potentially working with other folks that provide support services, wraparound services, and group therapy. So the key points for today, 2 minutes over, blazing through here. So harm reduction is a set of policies meant to reduce the harm associated with drug use. But as I mentioned, I feel like we can expand that definition to anything that is about acceptance of behavior and working to reduce the harms associated with that behavior. If we're able to talk about these risks, screen for use disorders, and facilitate treatment, we can help prevent these outcomes that we don't want to see and the patients don't want to see. And prescribing buprenorphine, co-prescribing naloxone can go a long way. And basically, if we are able to respectfully and appropriately engage with people who use drugs, we can create opportunity for intervention where there otherwise would be none. Those are my references. I think I'm good.
Beautiful. Thank you, Bill, very much. It's kind of how we all feel right now, right? Is that what this image is of?
Are you guys looking at my comic book background?
Maybe yes.
I'm